I'm Susanna Fantoni. I'm 25. I was diagnosed with epilepsy when I was 3, and I got a VNS implant in October of 2019. This tiny little device has totally changed my life, so I'm super excited to be here interviewing Dr. David McCormick.
Yeah, hi Susanna, thanks. So I'm David McCormick. I'm one of the consultants in paediatric neurology at King's College Hospital in London, where I lead the Paediatric Neurosciences Service. I've been working with VNS for 20 years since it started out.
Cool. So can you explain the basics of what VNS is?
Yeah, so vagus nerve stimulation is the implantation of a small electronic device with the battery in it in the upper left chest. And then there's a wire that runs under the skin to an electrode joined to the left vagus nerve. And really we're piggybacking onto one of the body's own nerves to send stimulations up to the brain to try and suppress seizure activity before a seizure happens if possible, but during it if we need to. So it's moving away from medicine and using electricity and tech to try and help control the epilepsy alongside the medicine.
So VNS comes with 3 different modes. So can you explain what each of them do?
We often program it to be 30 seconds on, 5 minutes off at the start. It's intermittent stimulation. That's called cycling or regular mode. There's magnet mode. So the device is designed so that it will respond to a magnet. And if it's swiped over the device, that will give a boost dose, which parents, the patient or their carer can do during a seizure to try and shorten it or stop it. And in the modern version of the device, it's measuring the heart rate all the time. And if it perceives that there's a jump in heart rate associated with a seizure of a particular type, it'll deliver the booster dose itself. So it's almost like an automatic magnet mode. And one of the cool things, Susanna, is that we found from our research that the heart rate jump sometimes happens 45 seconds before the seizure happens, so we can get in early.
All of these different modes can be altered to fit each patient. So do you want to tell us a little bit more about that?
Yeah, I often say when I'm training other doctors and nurses, and a lot of epilepsy nurse specialists do this programming, that VNS, although it involves an operation, is quite like a medicine, because you can put the dose up, you can put the dose down, you can alter the timing, you can start it, you can stop it. First of all, the current we use can be varied in a window. Some people find a high current gives them a little bit too much tingling in the throat, or they might have a little cough, so we can take it down. And we've got lots of other sort of knobs and fiddly bits we can twizzle to help with that. We can alter how sensitive it is to heart rate changes. So yours might be set at a heart rate change of 40%. So if your heart rate was 100, it would have to jump to 140 to trigger. But I could make someone respond at 20%. And the newest device we've got, called a Sentiva, we can program it to stimulate differently in 2 different parts of the day. So it could be that if somebody's got juvenile myoclonic epilepsy and they're having a lot of seizures after they wake up from sleep in the morning, we really want them to have a lot of stimulation in the morning, but they don't need it so much later in the day. Or maybe somebody doesn't tolerate the stimulation at night, but they don't have nocturnal seizures, so we turn it down at night. So there's all sorts of adaptations: dose, timing, triggering for the autostim.
If a patient were to come to you and say you're a patient's parent, because you're pediatric, so that they're interested in VNS, how do you assess whether or not they're a good match for the surgery?
There are a few types of epilepsy that perhaps respond a bit more. We know patients with tuberous sclerosis do really well on VNS, and we know patients with focal seizures, based on their seizure type and their EEG, do a bit better, but it's shown good responses for some people with absences, myoclonic jerks. Short answer, we can't tell whether one patient in front of us will be a responder or a non-responder, but we look for people who are refractory to medicines, still having seizures on medicines, who have been appropriately investigated to make sure they can't have direct epilepsy surgery. We would always go for that if we could remove a lesion or part of the brain, and then think a bit about their seizure type or syndrome. But it's very hard to pick who will respond and who won't. It's a bit like trying a new medicine.
So moving on, obviously you have to have surgery to have it implanted. It's often sort of referred to as a seizure pacemaker. how often do patients need to get the batteries from their devices changed, and how big of a surgery is that in comparison to the first surgery?
So first of all, why don't we talk about the first surgery? If you do have a vagus nerve stimulator implanted, you will have two incisions on your body. One is on the chest and is about that long, and to have the device put in, but it's like a sort of slightly thick 50p size, the modern ones. And a second one is an incision on the neck, which is really pretty short, like 2 centimeters. And they often heal down to be little fine lines. In answer to the second bit of your question, the batteries and the device are the same thing. So we would like to think that we could have rechargeable devices, but the tech's not there yet. And so often it has to be reimplanted about every 5 years, and it's only the chest incision that has to be touched. We don't go near the neck again. And it's so much easier because they've been there before. So they're in and out of the same little scar that you've got. And we do our surgery as day case surgery. People don't have to stay overnight. The operation for the first implant takes about an hour. You wait a few hours in hospital and go home the same day.
Why do you think it's taken so long for it to become mainstream amongst epilepsy treatment?
So I think one answer is that doctors and the public have trouble with an idea that's a device, not a medication. They think, how does this work? And I think there's a real need for us to move our thinking about illness and about how we treat illness from not just medicines to technology and to implantable technology, because I think that's a big part of the future of medicine. I think people have taken a long time, especially with epilepsy, to think something that's not a medicine and is not brain surgery can work, even though the evidence has been there and is growing all the time.
No, I think for me, I was a little concerned at first, mainly because to me, it felt like a last resort. You balance it out and you realize that you really have nothing to lose by going for the surgery, but potentially an awful lot to gain.
Yeah, it's interesting you say as last resort. I guess my message should be that it isn't a treatment of last resort. It's one of the treatments in our list. And if you've had 2 or more epilepsy medicines and are still having seizures, we should be considering at that point. Doctors are still implanting way too late. Our youngest patients would be about 3 or 4 years of age, but you don't have to wait years and years and years. And there's good evidence that if you get in earlier, at a younger age and an earlier stage in a patient's epilepsy in their life, that they respond better. We've got lots of papers about that. So it's not a treatment of last resort. It's one of the options of treatment.
Well, thank you very much for talking to us. And I hope viewers enjoyed and learned a lot from this interview.